Okay, I want to start out just by clarifying something I said in our last lecture about tuberculosis. So I mentioned up to about a third or a quarter of the world's population is infected with TB. What I meant is that they're infected with latent TB. So in the U.S., up to 13 million people have latent TB, according to the CDC. So remember, that means they're not infectious, but they have the potential to become infectious. They have potential to become active TB, where they're, having all of the signs and symptoms of TB. So we think that only about 1 out of 10 people that have latent TB actually progress to active TB, but we do want to treat those people with latent TB just to make sure that there's not the possibility that they will eventually spread it. And again, we talked about how nasty that treatment regimen is, but that's the current recommendation anyway. So I want to move on to the gram-negative cocci. There's really one major genera that is disease-causing in humans, and that's the Neisseria. In lab, we don't use any gram-negative cocci, but there are some out there, right? So let's look at the characteristics of this genus Neisseria. They typically present as Diplococcus. So you can see that over here most of the time, pairs, cocci in pairs. They usually are considered non-motile. Depends on whether you call twitching motility a true type of motility. So I'll write down twitching motility. So they're some consider them non-motile because they don't have flagella. Remember I said that's typically cocci, round cells typically don't have flagella. I don't know of any exceptions there. But Neisseria do have, your book calls these fimbriae, and typically we said if there are lots of them, then we call them fimbriae. If a cell only has 1 or 2, we typically call them pili, or 1 pilus. So your book calls them fimbriae. Most any other source that I read that talks about Neisseria calls these pili. So remember, it's the same composition. They're both made of pilin, this protein pilin. Those two terms are used a little bit interchangeably. Again, the book calls them fimbriae. I'm probably going to call them pili. But a twitching motility just involves an organism with pili reaching out, attaching to some surface, and then drawing the pili in to move that cell closer to whatever that surface is. So it's a very slow kind of motility, again, if you want to call it that. This genus is oxidase positive. And that's, we mentioned that briefly when we were talking about metabolism. That just means it has a particular cytochrome in the electron transport system, or the electron transport chain, I guess we called it. Okay, so this is an enzyme that it doesn't have anything, it's not oxidation, it's not an oxidation test, it's an enzyme that we test for, again, to see if this cytochrome, this protein, is present or not. And again, we didn't test for it in 213. If you take one of the upper level microbiology labs, then you will use it to test for, because there's a huge group of gram-negative rod-shaped organisms that are negative for oxidase. And that's helpful really just for identification purposes to tell those separate from a whole group of gram-negatives that does have oxidase, like Neisseria, like Pseudomonas, for example, and alkylogenes. All right. Mostly the Neisseria are aerobes. There are some that are capnophiles, some that grow a little bit better in high carbon dioxide concentration, kind of like the Streptococcus. We consider them fastidious. They are picky eaters, all right? They are, like I mentioned, they're very difficult to grow in lab. You have to get a certain kind of medium that they like. I think it's some kind of chocolate agar, which sounds kind of crazy. So they're considered very difficult to grow in the lab. And the two species that we're going to talk about are Neisseria gonorrhoeae, causative agent of gonorrhea, and probably the most difficult to spell of any of the organisms that we'll come in contact with. Also referred to as gonococcus in the literature some places, or used to be. And then there's Neisseria meningitidis. Okay, causative agent of meningitis. Of course, there are at least several different organisms that can cause meningitis. We talked about Staph aureus can do that. This is considered meningococcal meningitis, okay, or sometimes we refer to it as meningococcus. Right, so this video we're going to focus on Neisseria gonorrhoeae. It's a causative agent of gonorrhea, like I mentioned before, and this is a true pathogen. So it has a very low infectious dose. Anyone can get it. Doesn't matter how healthy you are, anybody can get it. In terms of transmission, and humans are the only reservoir here, we're passing it around amongst humans, sexual intercourse, probably the most common way. And of course, somebody with more partners is much more likely to contract it. Okay, it's typically carried by the sperm and bodily fluids. Okay, and due to differences in anatomy, there's different places targeted. Okay, for the males, the urethra is targeted. And in females, cervix is targeted. Okay, so males are more likely to give the infection to females rather than the other way around, right? Because typically the bacteria hitches a ride on sperm. Okay. Also can be transmitted mother to child. And as we'll see in females, the infection is very often asymptomatic, so they don't even know that they have it. Plus, some women wouldn't be likely to admit that they potentially could have it. So just as a matter of course, when babies are born, we always treat their eyes. We used to treat them with silver nitrate. It's a little bit more irritating than what antibiotics are. So typically we use some kind of antibiotic, like some kind of macrolide, like erythromycin or zithromycin, and put those drops in babies' eyes just to keep them from contracting gonorrhea during the birthing process. In newborns, gonorrhea causes an eye infection that can lead to blindness. So we just routinely treat any baby that's born kind of just as a precaution. Okay, so again, eye infection in newborns that can lead to blindness. Okay, there are a number of virulence factors that make this organism successful in causing disease. Number one, we'll talk about the pili, or fimbriae, if you want to call it that. Primarily, the pili are going to function in attachment to epithelial cells. In the urogenital tract. Okay. There are several properties of pili that have made it very difficult actually for us to make a vaccine. It's those proteins that make up pili that are the most antigenic. Okay, so that's primarily what our immune system recognizes. And the problem is that those proteins can change a little bit. Okay, so let's say properties of pili. Okay, number one, the pili can undergo antigenic variation. Okay, and that just means the composition of those proteins that make up the pili changes actually very quickly. Changes as soon as the host mounts an antibody response. Okay, and these are not just random mutations. When Dr. Bachter teaches MedBacT, he likes to go into this extensively because he finds it so interesting, the mechanisms that happens. Other organisms can do antigenic variation as well. HIV is quite good at that. Influenza does it much more slowly. Streptococcus can change the M protein composition a little bit, but Neisseria gonorrhoeae is particularly good at this. Again, as soon as our adaptive immunity ramps up and starts making antibodies to the pili, they change, and then the antibodies aren't any good anymore. Okay, another property of pili, they can do what's called phase variation. And that just means that the expression of these proteins can be turned on and off. Kind of like a switch. So essentially what that means is that the pili can detach. All right, so this is an interesting strategy. This is like if you're getting chased by a polar bear, what do? You run as hard as you can and you throw your hat or you throw your mitten and hope that the polar bear stops to smell it a little bit to give you a little more time to get away. All right, so if you think about our immune system as sort of chasing one of these bacterial cells, if they detach their pili, right, that's what our immune system focuses on. All right, so again, it's just another way, strategy that the Neisseria gonorrhoeae used to evade our immune system. Let's see, what else? One particular exoenzyme, we'll just call it protease. So a protease is, again, an enzyme that acts to break down proteins. In particular, what it does is cleaves immunoglobulin A, IgA. And if you remember what's special about IgA, it's the dominant isotype of antibody that we have on our mucosal surfaces. So that's where the Neisseria gonorrhoeae is trying to attach. What about a polysaccharide capsule? Well, that is actually, does it have one or does it not have one? That's actually a little bit more complicated question. Your book actually says that it does because we can induce these organisms to produce capsules in the lab, depending on what media we grow them on. Okay, but we think the answer typically is no. Again, even though the book says yes, pretty much everything else I read about this organism is that they don't produce capsules. That's a really important question because for the Neisseria meningitidis, for example, our vaccine that we have targets the capsule. And so that's actually what enables us to have a vaccine. Because there's no capsule for the gonorrhoeae, we don't have a good vaccine for it. And in addition, to all this, antigenic variation, we think that probably a vaccine is not going to be possible. Okay, one more thing to mention, LOS. Okay, that stands for lipooligosaccharide. Okay, it's actually a form of LPS, lipopolysaccharide. Okay, it actually has a little shorter sugar unit on it, but this is essentially a form of endotoxin. Okay, so what does endotoxin do? Remember, it causes inflammation in our bodies. No exotoxins for this particular organism. All right, let's move on to symptoms of gonorrhea. So sorry about the graphic picture. It's not fun to think about. Worst thing we can do is pretend it can't happen to us. Symptoms in males and females are different. Typically, they're going to start somewhere between 2 and 7 days after exposure. And for males, it's pretty painful. Burning while urinating. I've read it described as like peeing fire. Okay, a pus-filled discharge. Again, it's painful enough that males typically are going to seek treatment. Right now, we do have antibiotics that are still working. We'll talk about that in a minute. So typically, because they seek treatment, because it's so painful, typically does not get to the point of causing infertility. Typically doesn't get to the point where it's disseminating and causing some other wide range effects like arthritis and skin rashes and even endocarditis, so some crazy stuff. Again, get treatment and you don't get to that part. Females, it's a little bit more complicated because most of the time they're not feeling any symptoms. So you might think, well, no problem then, but that doesn't mean that it's not doing any damage. When there are symptoms, they are often confused with something else. So painful urination, well, that's might commonly be a urinary tract infection in females, or some vaginal discharge might be due to a yeast infection. So if these things are treated in an inappropriate way, it's not going to do any good. If the infection persists, we can have some more serious complications. A chronic infection can lead to the scarring of the fallopian tubes because the cells can migrate from the cervix deeper into the uterus, cause fever, inflammation, abdominal pain. That's how we describe pelvic inflammatory disease, or PID. Now, there are other infections that can cause that, like chlamydia as well. But again, this can lead to some scarring of fallopian tubes, which can lead to infertility or an ectopic pregnancy. So some pretty serious complications, and we want to get this treated. All right, what about the incidence? Who can get it? So remember, incidence describes the number of new cases of an infection. If you look at this graph in your book, it's kind of interesting. So it looks like, of course, there's a lot of cases that are not reported for this, but it looked like we were peaking here in the 70s, started going down after that. Remember what was happening in the world at that time, the AIDS epidemic. So people started, having safer sex, and we think, the incidence has come down quite a bit from then. If you look at your figure in your book, which is updated, we see an uptick like this at the end. All right, so we think You know, in 2018, the incidence has risen quite a bit from 2017. Of course, we're probably not counting everybody, but how do we explain that? I found an article in the Detroit Free Press a year or two ago that was trying to explain that. And no one particular reason stands out, but we think that perhaps the inconsistent use of condoms, maybe people aren't as afraid of HIV as they used to. Perhaps people are having multiple sex partners now more often due to the popularity of dating apps. It's kind of interesting to think about. Nationally, the last few years, there's been a lot of public health funding cuts. So clinics closing, that sort of thing. So, you know, maybe some of those things account for the rise nationally. But 18 to 24-year-olds are the most, is a population that's most at risk, or we could say most commonly contract gonorrhea. Okay, they're probably the ones most sexually active. And it's the second most common sexually transmitted disease. Chlamydia is number one. All right, so like I said, anybody can get gonorrhea. There are populations that are more at risk if someone has a complement deficiency, the autoimmune infection lupus, those people are more at risk. I'm not sure the connection there. Obviously, if you have HIV, you're more at risk, or an IV drug user, and just obviously people with multiple sex partners, and women. Okay, women are, men are more likely to spread it to women rather than the other way around. And I should mention this article from the Detroit Free Press that I mentioned talked about the disseminated gonococcal infections, which they refer to as DGI. They're seeing a little uptake in those. So remember, that's when gonorrhea goes untreated. It can be males or females. It can get to the bloodstream and causes just a wide range of symptoms. Things that are not normally associated with a sexually transmitted disease, like joint pain, fever, chills, stiffness, swelling, that kind of stuff. Okay, the good news is for now, gonorrhea is still treatable very easily. Penicillin's no longer effective, but according to the current CDC guidelines, cephalosporins are most commonly used. Remember, that's a beta-lactam, so cephalosporins such as ceftriaxone is injected. Remember, the later generation cephalosporins typically have to be injected. Usually use, again, a cephalosporin in combination with azithromycin or doxycycline, which is a tetracycline, one that we didn't talk about before. Remember, azithromycin is a macrolide. Okay, and it's really interesting to look at the evolution of treatment. This is a 4-minute video that I got off the CDC website, and it really makes you stop and think about the antibiotic resistance and how we've tracked it over the years, and how, you know, drugs to treat gonorrhea have been very effective, and then a few years later, suddenly they're not. We're having a huge problem in Southeast Asia right now with strains resistant to this combination of drugs. They have some strains that aren't responding to any kind of antibiotic therapy. So basically, when that happens, you have to focus on just prevention. So abstinence, monogamy, condom use. Okay, is there a vaccine? So remember we talked about we have good vaccines for infections that you get once and then, you have good memory cells and you don't get it again. Well, due to the antigenic variation of not only those pili proteins, but the cell wall proteins to some extent as well, we don't have any immunity to second exposure. We don't have any memory cells that recognize it, so we can get it again and again. So nope, we don't have a vaccine, and as far as I know, there's not any on the horizon as well. Okay, so next video we'll go on to Neisseria meningitidis.